Now we are starting for the second part. So, and this is really something that I'm interested now to understand a little bit better what what our speaker and also the other panel discussants are really doing in their clinical practice, and now they use this technique in which order and for which kind of patient in clinical practice. So let me start by asking maybe the first question to Francesca. We heard already also what Ugo said about the defecography, that this technique indeed has the added value that you can really study also the anatomical conformation of the anorectal area. So does this mean that we need to basically test all our patients presenting with obstructive defecation with the defecography, or what is your opinion? How we need to select this patient for this technique?
Thank you so much, Maura. Thank you, Mark, for inviting me as a radiologist. This is a very interesting clinical meeting. And, you know, let me tell you first, just to answer also Ugo Grossi, that I believe that today in 2021 is MRI, the technique to assess anatomical changes in the pelvic floor. It's no longer conventional defecography. Conventional defecography is an extraordinary examination because it allows evaluation in sitting position, in physiological position. And this is the force, the main strength of conventional defecography. But on the other hand, it provides just very poor anatomical details. Instead, with MRI, we can see really everything in the pelvis, everything. We can study the nerves, the pelvic nerves. We can study the muscles, all the muscles, of course, the external, internal sphincter, the puborectalis muscle, whatever you want. And we can perform functional imaging, but we have to choose what we want first, because we cannot perform all together in the same time. So in my opinion, first of all, the main message is to involve radiologists in this field, is to discuss with radiologists what you want, radiologists involved in MRI, for example, or in GI imaging, conventional GI imaging, because what you may obtain from this examination depends from the interaction that you have with them. First concept. Second, would I perform? Yes, if possible, but this is not possible to perform in everybody. So of course, all those patients that you think may benefit of surgery, of course, yes, because I think surgeons want to know what the degree, the amount of disease, of disorder at any anatomic level, anterior compartment, middle or posterior compartment, the extent of rectus here rather than posterior prolapse or whatever. Instead, if there is a very strong possibility of a functional disorders due to anamnestic information and symptoms, of course, the role of test is mandatory. I would never trust on MRI only or on the conventional defecography only. I think it's the association of the two. And of course, you may also perform only functional study, but don't forget that in many cases, mechanical problems are associated with functional problems in many patients. So it's not easy to foresee what will benefit only of functional study without a morphological study. So it's a huge, I think this requires a large debate.
Yeah, I think that is interesting what you said about the fact that you think that MRI is really the technique, but we need to also to recognize that not every center has this possibility.
Yes,
so, of course, this is a major problem. And I think that you point on a very important aspect that sometimes, at least also in my experience, is not easy to really have a dedicated radiologist, a radiologist that is interested in this kind of technique, that is considered by the radiologist a kind of really less fancy and attractive technique. So do you have any suggestion on how, what really
my suggestion
made you
is to invite your radiologist to your clinical meeting, to involve them in the clinical issue. In Rome, I was grown up with a large gastroenterology units. Maybe Corazziari, Enrico Corazziali, and Caprilli was the founder of the ECHO, and they were my teachers. So of course I was involved very much. And so this is your job. So you need really to grown up your radiologist, because trust me, today imaging can offer you so much and can be such a great help for surgeons, but for clinicians as well. So I think a radiologist may offer you many important information in many different cases.
We need probably to value more our radiologists and really make them feeling important in our.
When I answer to this question that are very common, I'm also very much involved in Crohn's disease. It's just always the same. Oh, but we don't have GI radiologists. We don't have MRI. Blah 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 blah. Okay. Just think to the neurologist and neurosurgeon. Do you think they would ever see a patient without MRI? No. They perform any kind of test, but they need MRI, and you will need MRI more and more in the future. This is my opinion. But of course, this has to grow, to become. So it's, and I'm sure that in the future also, maybe it would be possible to apply functional tests during MRI, whatever. It will be very open to any, because MRI is changing. And so there are many
I totally
options.
Okay. I totally agree. So, on this, Mark.
Sorry, can I ask you a question? Because as you've already heard, a major controversy in manometry is the assessment of anorectal coordination. You call it anismus, we tend to call it dyssynergia. There are different kinds, some with active contraction, some without. But I'm just curious, do you think when we talk, gastroenterologists talk about anismus dyssynergia, are we talking about the same thing as radiologists? Or do the, shall we call it, paradoxical movements of the anatomy, can they be caused purely by anatomical disturbances and rather than just abnormal behavior, which is, I think, what most of us are focused on?
Mark, I think this is it's a field that still need to be investigated by us radiologists together with you gastroenterologists, because let me tell you this, I can, of course, evaluate the opening of the puborectalis muscle with several signs on MRI as well, also in supine position. The first is the angle that I just mentioned in my presentation. It's important to evaluate the opening of the puborectalis muscle. But there is another important sign, which is the pressure, the abdominal pressure, the increase of the abdominal pressure and the coordination that we can see very well, but we underestimate in our evaluation probably. So what we call anismo-puborectalis syndrome is the abnormal opening of this angle and the reduce incomplete evacuation, possibly lack of evacuation at 3-4 attempts. So we do not have standardized measures, standardized criteria, particularly for functional disorders. They are, in my opinion, they need to be investigated much more. And I always ask for a functional study after, if the patient didn't perform a manometry, I always ask for a manometry to confirm the hypothesis of a pubertalis syndrome in my examination. But I think there is a lot to learn on MRI, because we really see the synergy. We see if the patient increase the abdominal pressure, if there is an increased abdominal pressure over pelvic organs or not. We see many things, but we are not used to detect them. So I think it's a word that needs to be open. This is my opinion.
Can I ask a query
sure.
from the radiology point of view? Because one of my great concerns as a clinician is the risk of iatrogenic harm. And we know that it is very common to see structural abnormalities on proctography, both MRI and definitely conventional. And there often is therefore a lot of fixation of patients on the fact that there may be a small rectocele and this is what is contributing, for example. And we know clinically that even in that group, and particularly where there may well be coordination and targets on manometry, that going to conservative therapy and biofeedback can actually improve their outcomes without any intervention, which is why I tend to take the approach of looking at that treatment target that we can start off and go with the least invasive and move up. How do you go about your reporting of what is a significant anatomical abnormality in that patient at that time?
Yeah,
excellent question.
I in the first phases of my experience, I used to distinguish between purely functional or just pure anismus, the patient cannot evacuate, doesn't open the anorectal angle. These need to be confirmed with manometry and so on. And all mechanical disorders such as rectocele and blah, 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 and invagination, whatever. Now that I'm more experienced, I see much more frequently the signs of pubertalis spasm associated with rectocele, but even severe rectocele. So when I see, I mention, but this, it's a training. At first, I couldn't see all these signs. Now I see more and more mixed form of mechanical and functional obstructions. So I think this is an important field to investigate together, because sometimes you don't see those signs in some rectocele or some, there is a large spectrum of disorders, but frequently I see those signs. So I think that they probably are sort of evolution of a purely functional disorder toward mechanical disorder. So this is a very interesting point to investigate together, because we can really show you this feature with MRI. So for this reason, it's important to work together, because we learn a lot from you, and you may take a lot of information from radiologists and MRI as well. So I think the more you are involved, the more it's interesting, of course.
Yeah. And can I now ask something? I was interested in what Rebecca said about the phenotypes, and really the importance of speaking with the patient and really understanding what is the problem of the patient, and then kind of targeting the investigation to the symptoms of the patient. And something that I have been always interested in is the fact that in my clinical practice, I noticed that, and this is something that is also emerging in the literature, that patients, for example, with IBS and constipation tend to have probably a normal frequency of bowel movement, but to report this sensation of incomplete evacuation, sometimes they digitate, and my feeling is that they are different from the patient that complain probably of less frequent bowel movement. They digitate, but probably they have not so an hypersensitive rectum like the IBS. So I see this, and I use the manometry as a kind of extension to confirm this finding. Can you comment on this, if this is also your perception, and if you use also the anorectal manometry in this way?
Is that a question for me or for Emma?
For Rebecca. for Rebecca.
Yeah, so I would agree with you there. As you probably noticed from my talk, I think the arbitrary kind of classification of chronic constipation versus IBS-C is not that useful clinically, because there is such a large overlap, and really the predominant symptom type for me is more important. There definitely is that group of patients where this appears to be more of a sensory problem and a visceral sensory problem that tend to fall more into the IBS-C kind of camp, for want of a better word. And I do use manometry, and particularly the rectal sensory test in that setting as well. And again, as a treatment to target. So if I find that there is clear visceral hypersensitivity, I am more likely to target that as my treatment, whether by using balloon retraining or medications as well. The other thing as well with IBS is that kind of pain component. You know, the patients that fall more into the chronic constipation group, the infrequency, yes, they do have abdominal pain. They do tend to respond that pain better to laxation and kind of resolving the fecal distension of the bowel, whereas we don't quite see that happening in the IBS group. They tend to have pain ongoing, even if you have improved their stool consistency and function. So it is slightly different in that group. But again, I tend to use symptoms more as an individual rather than the overall Rome classification for defining them.
Okay. And Ugo, do you have any comment on this aspect?
Yeah, no, I mean, I've always found so tricky to distinguish between an abnormality per se, or an abnormality which really is obstructing defecation. So we always talk about structural abnormalities, rectal invagination, but we have the it's very hard to determine when this abnormality is something for which we need to call the surgeon to fix, and it's really contributing to an evacuatory disorder or not. So, I mean, this is why I'm telling, this is one of the reasons I support radiology in the setting of, in the workup of a patient with constipation.
And do any of you use also questionnaire to really phenotype the patient, or just rely on the symptoms that you request to the patient? How useful do you think are the questionnaire to phenotyping this patient? So
I do use questionnaires, both for my patients that are undergoing manometry and functional testing. And I also use the Rome Diagnostic Questionnaire on all our patients that have come through our clinic.
The whole thing?
Big sigh on the whole thing. There's a big sigh on that front, because I'm actually in the process of reviewing my practice on that, because I haven't found it helpful.
Okay.
Do you think that we should be asking these questions as they stand in the questionnaires, or do you think we have to be more subtle? I mean, there's this shift in immunology from just counting cells to working out how the cells are functioning. Do you think that, you know, we shouldn't be just asking about straining, but trying to explore a bit more why, sort of how this straining is occurring? For example, I mean, when the patient is straining and the stool is soft, this is a rather different situation as when they're straining when the stool is hard. We would probably all strain if the stool is hard, you know.
Questionnaires are really important as a screen, and nothing replaces history taking an examination in this space. Yeah. Unfortunately, it's old school. We can have as much technology in the world, but really sitting down and talking to the patient. But questionnaires are a really useful screening tool, and I think they're also really important to remind us as doctors to ask a bit more broadly. And I think that's really highlighted by the overlap between incontinence and constipation. So I do screen all my patients with both incontinence questionnaires and constipation questionnaires. And I do get the odd patient that says, oh, I don't know why you put both of these in this, because this one clearly does not apply to me. However, that's rare. That's very rare. And when I get that, I'm like, oh, okay, well, I've got a pure constipation here. Most of the patients will feel comfortable in the privacy of their home, ticking a box that says, oh, yes, I have an issue with that, but maybe they've never discussed it with anyone else before. So for me as a clinician, that's really useful, because then I can kind of drill down on that a bit more in the history, and get a lot of useful information. There's a lot of people out there that have quite significant problems with continence and control and leakage, and they're just presenting with constipation to you.
Yeah, it's true.
I use the questionnaires mostly so that I can compare my patient's practice to others in other institutions, but I don't find them a very useful tool for decision making. I have a very structured way on interrogating a patient's bowel habit, which I have developed personally over, my own personal way of doing it, in which I explore in a lot of detail about the urge, evacuatory attempts, mechanisms for evacuation, leakage, return to the lavatory. I explore it all in a lot of detail. And that is what I use for my clinical decision making. I'm sure everyone will say the same thing. I do think it's important to use structured questionnaires, but I have never found a patient with a questionnaire response which I have thought is a lot different to that in which I've inquired through my history taking. But that being said, I do think it's important because, they are validated. Could they be improved, Maura? Absolutely. There's so much work that needs to be done on them. I find them very, and I find this a really frustrating area of our practice, because moving away from standardized questionnaires is a big deal. Changing to a new questionnaire is a big deal, because all of our studies over decades have been based on outcomes on one questionnaire, however good or bad it is. And I'm not going to name names, but if I could change one thing about our field, it would be taking away some of those validated questionnaires, which may be questionably validated with the retrospectoscope. So
we're now all waiting for the Carrington checklist.
Oh God, I don't know whether I've got enough, social currency, academic currency to try that one out. But I do think about it from time to time.
Yeah, there's definitely a lot of improvements that can be made there, because with this space, this is not just a physical condition. There is a large voluntary component here. I see a lot of patients that have significant OCD as
definitely
contributors to their presentation. Actually, I see a large number of patients with autism with significant defecatory dysfunction, and a lot of that, there's definite physiological components, but there's also some fairly major psychological components as well. And none of the questionnaires that we have in use detect any of that. But it is a very useful starting point, and it's a very useful way of us making sure we're not missing something that we need to ask about.
Yeah, and I have to say that. Sorry. I have to say that I frequently refer also for the anorectal manometry, as I said, to confirm this, but also because this is a space where normally the patient open with a physiologist and really tells something that probably in clinical practice we don't have the time to explore. So I think that this is also an extension, a place where the patient feel comfortable because it's frequently in a room for longer time than the normal consultation. And is also the moment where you really discover that patient has kind of sometimes of obsession, and they have this strange pattern of really using some kind of strange technique to really defecate or to really open the bowel. And I think that this is also something that, of course, you cannot really test in a study or in a scientific study, but it's quite important, and it is frequently a lot useful in clinical practice.
I strongly agree with that. And the other thing that I also feel is really important is that the clinician reporting the manometry study is the one that's doing the manometry study.
Absolutely.
I find so much more information.
Couldn't agree with you more.
On their technique. Are they using their abdominal muscles? So I do also do, I guess, a little mini biofeedback session sometimes in the examination to see whether this is just something that's really easily correctable or if this is very entrenched behaviour. And I'm always very surprised when people say that their nurse just does the test and they look at it later and give the diagnosis. I just think you miss so much in that. It's really an extension of my clinical examination rather than a standalone test.
And can I bring a question back in? I'm sorry to do this, everyone, but we talked in the other session a little bit about balloon expulsion versus dephecography. We're now talking about dephecography and MR proctography. And I want to bring it in at this point because I've changed my mind about the balloon expulsion test recently, because I see it in a different part of my investigative protocol than I do evacuation proctography and MR dephecography, because I see it as one, we're still using the term anorectal manometry, and I want us to move away from that term because I want us to start using the term anorectal function tests, meaning that we never refer anyone for manometry. We only refer people for the 3 tests, and that is rectal sensory test, anorectal manometry, and balloon expulsion test. Yeah, because to me they now come as a package. So to me now, the balloon expulsion test is an important adjunct to the manometry, that you do the manometry, you look at the rectal anal coordination, and then the balloon expulsion comes with manometry. It's now part of the package. Yeah. And after that is when I start wanting to examine the posterior compartment. I want to examine their defecatory parameters when they're in sitting position. So I'm just kind of interested in, you were just saying, Rebecca, just now about how you perform your clinical examination. You get a feel for them, when they're undergoing their anorectal function test, about their defecatory maneuvers. And I'm just interested in sort of how you do that when you're separated from your evacuation and that evaluation. So how do you do it if you're not testing evacuation then and there? With the balloon. And also, how do you then bring in the London classification? Because you're interpreting your manometry, but you can't test the third part. You can't give your third part of the London classification unless you've done both the balloon expulsion or your test of evacuation and manometry. And maybe this is something challenging that you're going to tell me to change. Maybe you're going to tell me, well, actually, the London classification doesn't work because people aren't using it because they don't like the balloon expulsion test. But I'm just really interested in what you think about that little rant. Sorry, everyone.
No, look, it's a really good question. It's something that I've really been giving a large amount of thought to for some time. The first thing to say is that the manometry studies that we do is 3D high-resolution manometry in our group as well, which the London classification is not strictly aligned to anyway. In addition, it is more difficult, therefore, to do a balloon expulsion test as part of that. It is a completely separate examination because of the nature of the probe as well. So I think that's one of the factors that went into my decision making. The second one is that, if I was doing this for a large research study and I'm wanting to rule in evacuatory dysfunction is the question, then I think balloon expulsion is the best test for that. Apologies, Francesca. I think proctography is very important, but in that kind of ruling in out, that is where balloon expulsion comes into the fore. And I think it is a very good test. And it is something that I do in a subgroup of patients. But for me, the physiology study is really asking that question of, do I have a target for treatment here? And while balloon expulsion itself, back in the day, as a definition of is pelvic floor dysfunction or not, yes, it predicts the outcomes with biofeedback there. But if I have a patient that has really significant rectal evacuatory dysfunction on symptoms anyway, really the question I want to know is there a pattern of pelvic floor function on manometry that I can target and treat? And that's the question I'm answering with manometry there. Not really, is this a rule in, rule out of rectal evacuatory dysfunction, a rule in of rectal evacuatory dysfunction. It's a rule out of the kind of patterns that we would see to target for biofeedback.
Yeah. And Ugo, what is your comment about this? So are you routinely using the balloon expulsion test in your clinical practice or not? And did you change also your mind like Emma recently or not? And then after this we can probably close. Yeah.
Yeah. We routinely test patients coming from an rectal physiology test with both the maneuvers. So we do perform an rectal manometry and then ask the patient to evacuate the balloon in the toilet in the sitting position.
This is also my practice.
The reason I would argue a little bit the other way, and I know it's kind of a controversial one. If I have a patient that has severe symptoms of evacuation and they have an abnormal pattern on manometry, even if they can expel the balloon, I think there's a target for treatment there anyway, because they're presenting with the symptoms. And I certainly some patients who strain excessively and get really high rectal pressures, and yet they can get that balloon out, but I don't think that's normal.
Emma, do you want to say?
Rebecca. No. Yeah. So actually, it's really interesting, Rebecca, and I agree with you. There are certain circumstances in I do, of course, I agree. I always agree with you, Rebecca. No, I do agree with you. Listen, neither of these tests are perfect. The balloon expulsion test is definitely not perfect. And there are definitely circumstances in which, your clinical acumen overrides an imperfect test. Absolutely. I agree with that. But but in those cases which are a little bit more borderline, and then I think it is useful in that stage. And don't get me wrong, a lot of my patients will go on to evacuation studies afterwards, but I think that when you've done your anal rectal function test, you've done your screening there, and most of my patients will go on to some form of pelvic floor physiotherapy and biofeedback. I am not going to go on to any surgical intervention until I'm absolutely certain that I have optimized their pelvic floor function as much as possible. There is, it's extraordinarily rare that my patients will not have any form of behavioral therapy before they go on to a surgical target, because I just think that you have to prepare the ground, as our surgeons, say, to make sure that your ducts are in line and you've done absolutely everything conservative you can do, and take away some of that, as you say, Francesca, that overlap in an anatomical abnormality, because of one thing I have no doubt, and that is people's functional ability is going to be worse in the post-operative period when they have pain and inflammation and all of that. And so you're correcting an anatomical problem, but you are definitely transiently worsening their functional problems.
So and on this note,
to
I agree completely.
On this note of agreement, general agreement, I think that we came probably to the conclusion. What do you think, Mark? We had a very interesting discussion, animated discussion.
I think that was great. I thank you, all of you, for taking the time this early morning or late evening, one or the other, and we'll all go home and enjoy our kiwi fruits and keep ourselves regular, and maybe also adopt the complete London classification, including balloon expulsional test from this moment on. Thank you very much, and thank you for all those watching this video for your attention. Good night.
See you. Bye-bye.
See you. Bye.